Welcome to the Jerry Pal Podcast. This is Eric Wadera.
This is Alex Smith.
Alex, who is our guest today?
Today I always say we have a special guest, but we have an extra special guest today. We have Kara Bischoff, who's from UCSF, who's assistant professor. She's in the Department of Hospital Medicine. She's a palliative care clinician, and she mostly does outpatient palliative care now. And she published a paper in JAMA Internal Medicine that we're going to talk about today.
Great, looking forward to it. We always ask our guests if they have a song for Alex to sing.
Well, sure. How about Landslide by Fleetwood Mac?
Great choice. The lyrics of this song are actually very Jerry Pal, as I discovered learning this song last night. You're going to sing with me, right?
Sure am, Alex.
All right, let's go.
Here goes nothing.
I took my love and I took it down. I climbed a mountain and I turned around. And I saw my reflection in the snow-covered hills till the landslide brought it down.
Maybe at the end, you both can do a little duet of that song.
That was a duet.
No, more of a duet.
Oh, more of the song.
More
of
duet.
the song.
More duet.
More song. Yeah, you have to go listen to the end of the podcast to hear the rest of the song.
Yeah, just like more
All right.
cowbell.
That's
More
motivation.
cowbell. That's what we need. We need Eric to play cowbell on these things.
Okay, I will bring a cowbell.
Next time, cowbell.
Amazing. Wait, when do I get invited back for the cowbell?
So, a paper in JAMA IM. Tell us about this.
Yeah, we're very excited for the opportunity. This is basically coming out of the PCQN team, which is myself and my colleague Steve Panelat. And
What does PCQN stand for?
Sure. The PCQN is the Palliative Care Quality Network. In short, this is a national registry in palliative care, and it's one of three in our country where palliative care consult teams, in this case we're reporting on inpatient consult teams, are part of this registry and collect data on patients they see for inpatient palliative care consultations.
This is like in the course of routine practice, they would be collecting data on their patients.
Exactly. Yeah. During our study period, we had 78 inpatient palliative care teams who are all collecting data on each of the patients that they saw.
And where were these teams?
Yeah, the teams were in 11 different states throughout the country, actually many in California because the network did start here in California. And they're at a really diverse range of hospitals, some small community hospitals, some public safety net hospitals, some large academic medical centers. It's quite a diverse group.
And it's interesting, this kind of research, it's not like you had people sign consent forms and do this sort of thing. It's sort of integrated into practice itself as part of is this part of quality improvement?
Yeah, exactly. And
Would that be the Q?
Sure was. You got to have a Q and a P and a C somewhere in there. So absolutely. I think one nice thing about this data set is that it allows you to take a glimpse at real world clinical practice rather than the practice that occurs in a study setting or even our own documentation practices.
That's great. So these are people who do inpatient palliative care, and are these mostly academic centers? Are these community? What are we talking about here?
The majority are actually small community hospitals, although there are a number of academic medical centers and public hospitals that participate.
So tell us, what were you studying here using this PCQN?
Sure. In short, we were trying to look at the advanced care planning that's happening real world currently for our inpatient palliative care teams. So which patients have advanced care planning needs, which patients are consulted for palliative care for their advanced care planning needs, what do the palliative care teams do regarding advanced care planning, and what are the clinical outcomes that result.
So this is kind of like, what's going on in the real world with palliative care teams? Who are they seeing? Why are they seeing them? What are they doing?
That's right.
Yeah. That's great. What an interesting study.
What did you find?
Sure. So amongst the 73,145 consultations, there were...
Wait. Can we just pause there? That's a lot of consultations.
73,000?
Absolutely. And maybe I should give a shout out to all of our members and great appreciation for their assistance collecting this data so that we can really understand this with a lot of power.
So 73,000 consultations. What were they for? Like, what are being people being consulted for?
Yeah. So actually, the majority of palliative care consults amongst the teams in the network were for advanced care planning. 72% of the consults were requested for that, amongst other reasons.
Do you have an idea what the other reasons were?
Yeah, absolutely. So in about half of the consults that were for advanced care planning, that was the only reason. But in 46% of those consults for advanced care planning, there are also additional reasons for the consult, such as a referral to hospice in 37% of cases, pain management in 30% of cases, other symptom management in 28% of cases.
What about the consult question we get, which is, we don't really know what the consult question is, but we just need your help. Is that a category?
Yeah. So in those cases, the Palliative Care Quality Network teams are challenged to pick something.
Right. They don't have a cry for help box.
Help.
Not yet.
I don't know what we want you to do, but we just want you involved.
It seems like advanced care planning. When so I guess advanced care planning is a wide spectrum. Is that a big basket? Like, what if is there a way of unpacking that? Like, what might go into advanced care planning? When I think about it, think about like goals of care conversations would fit in there. Think about like documentation of stuff would fit in there. Think about breaking bad news, prognosis discussions.
All of that would, in fact, fit in this bucket that we called care planning. And in fact, in the Palliative Care Quality Network database, we combined advanced care planning and goals of care discussions into a combined data element that was care planning, in recognition that for seriously ill inpatients, it's often difficult for clinicians to consistently distinguish what is advanced care planning and what is goals of care. There's so many conversations that we have that could be defined with both terms. So we use this generic term, care planning, to encompass discussions about people's values, hopes, worries, wishes, and then also their opinions about specific decisions that they're facing, including decisions such as code status, and documenting all of those wishes in documents such as advanced directives or POLST forms.
That's a great point. So not all goals of care discussions are about future decisions. Some of them are decisions we're making right now about their care. So it's not all advanced.
Definitely.
Yes, it's not right. So some of these things are happening now.
Yeah.
They're sick now. They're making decisions now, and some of these things are about the future.
Mm-hmm.
Is there a way of breaking that down? Did you look at those two categories separately?
We didn't. In the Palliative Care Quality Network database, they used to be separated, but what we found early on during pilot phases with the database is that it was difficult for seriously ill inpatients to really distinguish them. Mm-hmm. For instance, a team might be consulted for an elderly woman with a new diagnosis of pancreatic cancer. They might start with sort of advanced care planning discussion, understanding values and priorities broadly, perhaps determining who the surrogate would be. But then that consultation could also evolve to include a conversation about specific treatments that patient faces, which was more accurately categorized as goals of care. So that's why we have that combined data element, and we weren't able to separate them out.
Right. There's so much blurring of the boundaries there. I can understand why it'd be hard to separate out. And it rings true with like my clinical practice here, where most of the consults are for goals of care discussions or advanced care planning. I think. Do you think so, Eric? Yeah,
or specific symptoms, but they really want you to also talk to them about their goals. Or when you do talk about symptoms, the patient wants to talk about it, or you feel it's important to address.
Mm-hmm. Yeah, one thing that brings up is that for me is that in our study, we did find that even for these patients in whom the consult was requested for care planning, we actually found that quite a number of patients, 46% of patients, had other pain or other symptoms at the time that they were seen by the palliative care team. And over 50% had psychosocial needs. 27% had spiritual needs. So certainly these quote care planning consults were very complex and often involved many other aspects of care.
Maybe taking a step back before we go more into the results, how do you know they had all these needs? It was so a consult happens, palliative care team sees the patient, and then do they enter this information in the database?
Yes.
Or is it pulled from the EMR?
Exactly. No, the teams directly enter that data into the database about what assessments they did and what needs they identified, as well as what they did to intervene upon those needs.
There must be some variation, though, between settings, between hospitals. Like I remember in Boston when I was at the Brigham, most of the consults were for pain. In fact, the service was called the Pain and Palliative Care Team. So most of the consults were based on symptoms, and then you got to kind of get into the goals of care secondarily. So did you look at variation between these different sites? We
did, absolutely. And in the teams in our network during the study period that we examined here, there was a broad range from 27% to 99% of consults were for advanced care planning or goals of care. So you're completely right. Some hospitals are doing almost exclusively these types of consults, and in other hospitals it's the minority. So it's really interesting in the Palliative Care Quality Network to be able to examine the range and how the differences between teams.
So speaking of these consult teams, like what were they comprised of?
Yeah, absolutely. So in terms of the consults for advanced care planning, they occurred on average 4.7 days into the hospitalization. And that wasn't actually different than the timing for other palliative care consults. The advanced care planning consults involved doctors in 52% of cases. So just over half of these consults involved doctors. Social workers were involved in about 40% of these consults. Chaplains in 33%, registered nurses in 37%. So you'll notice that adds up to more than one because in some cases, multiple team members were involved. And patients were followed during these consults for care planning for a median of 3 days. And there's an average of 1.4 family meetings per consultation.
So I would imagine most teams probably have a doctor or a nurse practitioner or a registered nurse and a social worker. And some have a social worker, some have a chaplain, something like that?
Correct.
Was it different for other consults? Do you have that data? What the team makeup looked like?
Yeah, the consults for pain management and other symptom management are more frequently involve doctors or nurses. And the consults for psychosocial needs, spiritual distress, not surprisingly, involve social workers and chaplains respectively. But this was obviously a very common reason for consultation, so it sort of was right in the middle.
So did all of this care planning translate into new documentation?
Yeah, so we're jumping into the results, but yes, you're right. There was a lot of care planning that occurred. There were a lot of needs that were identified in these patients. There was a lot that teams did to try to address those needs. What we found is that teams very consistently identified surrogates for patients and very often addressed their preferences regarding life-sustaining treatments, including code status. And frequently, they found a preference regarding life-sustaining treatments that was different than what was previously documented before the consult. So though we weren't able to measure all the nuanced detail of exactly what was happening in those conversations, we think that there's a lot happening to clarify patients' wishes. However, to answer your question, it wasn't nearly as frequent that legal documents were completed, whether those be advance directive or physician's orders for life-sustaining treatment forms, to document those wishes.
And when you say not as much, like what numbers are we actually looking at here?
Sure, absolutely. So we looked at this a few different ways. Overall, an advance directive was completed for just 3.2% of patients. And
Whoa.
Wait, 3.2% of all the 70,000 patients, 3% had an advance directive documented?
Completed by the palliative care team.
What could have been completed by somebody else?
The Palliative Care Quality Network defines completion of advance directive as the work done by the palliative care team. Okay. So palliative care consult teams in the hospital are not doing advance directives very frequently.
Okay. Sometimes like on our consult service, we actually ask the team social worker, like not our palliative care team, but the primary team social worker to come back and fill out the advance directive, especially if it's just around surrogate decision makers. And that would not count, right?
Correct.
Okay.
What about documentation in the medical record that we had this advanced care planning conversation? This is the surrogate. The patient said that, they would like this sort of treatment under these circumstances, and their DNR, DNI. Did that count?
Yes. No, that was happening very frequently. So that was reported in the Palliative Care Quality Network, and it was happening very frequently. In fact, over 90% of patients had a surrogate documented. The vast majority had code status addressed, and quite a substantial proportion, so 31% more people indicated that they'd like to have a code status of DNR, DNI after the palliative care consult compared to before it. So certainly there was a lot that was occurring in those conversations and being documented in the medical record.
But it sounds like you're suggesting that palliative care teams ought to be completing the legal paperwork for what reason? So that these decisions are transferred with the patient across settings if they leave the hospital?
Well, thanks for asking that way. I don't think we have a pre-specified target that we think is the right answer for everybody. Rather, we wanted to highlight this so that folks can understand what palliative care teams are doing very consistently and what we're not doing. But we highlighted in the discussion that there are many reasons why a palliative care consult team may not do an advance directive. There may be other people in the hospital who can complete that document. And there's legal requirements, including notarization, that may not be realistic to complete during an acute hospitalization. So I think there's lots of reasons that number is low, and it may be appropriate for it to be low. I think the question about the ideal rate of POLST form completion is something that we've grappled with more. We still don't have an answer here. But we do think that this is an important document that can help patients get care consistent with their wishes. And we think that probably the 12.3% that we found, 12.3% rate that we found is too low.
12.3, sorry, what was the 12.3%?
So in 12.3% of these patients, overall, a POLST form was completed during the course of the palliative care consultation.
And are these, so the PCQN is more than California, but the POLST is only in some states.
That's correct. So there are some states or some teams in the Palliative Care Quality Network that don't have a POLST in their state. We still include them in these analyses because we still think it represents a quality gap. Those patients still don't have access to such a form. But you're right that those 8 or 10 patients are dragging down our average.
But not by much.
It's not out of 70,000.
Or 8 or 10 teams, I'm sorry.
8 or 10 teams.
Teams. Got it. Okay.
Out of the 57.
Still, it's an interesting question. Ought palliative care teams help patients? Are we missing? I mean, this could be a game-changing suggestion here. Palliative care teams, they seem like they're the right people to have these conversations. They seem like they're the right people to fill out these forms. And sure, there's some practical barriers. The notary thing is absolutely ridiculous.
But you don't need a notary for a POLST.
You don't need a notary for a POLST. Should we routinely be completing POLSTs on all patients in states where it's allowed?
Yeah, I think that's a great question. It's a conversation we've had a lot within the Palliative Care Quality Network. And I think it's been challenging for us to answer conclusively because many of us work in hospitals where we're really trying to promote primary palliative care. And we think that our hospital medicine colleagues and our other colleagues that we work closely with have a lot of skills and a lot of interest in serving their patients and providing care consistent with their preference. So we don't want to curtail their sort of involvement in primary palliative care, including completing POLSTs. In fact, we want to educate them and empower them to do that type of work themselves. However, we also realize that even when I've made those recommendations to primary teams quite recently, it doesn't always happen, and the conversation doesn't always happen in a high-quality way.
Yeah, so especially if we go in and have a goals of care discussion as far as a palliative care team, and it's clear to us that our recommendations are, let's say, DNR, and the patient agrees with that, and maybe the patient brings it up. It seems like an opportune time to actually document that instead of saying, great, and this other team of doctors are going to rehash this entire conversation, probably in a very different way, and may just say, do you want to be DNR or full code?
Or worse, hand the pink sheet to the patient and say, hey, we heard you talk with the palliative care team. Can you fill this out? And we'll come back and sign it.
Right.
So it does seem like a place where we can actually do some quality improvement amongst our palliative care teams.
I think so.
It's interesting. There's an analogy here with, we thought once we start having these goals of care conversations with patients as palliative care providers, then the residents and the primary teams are going to lose these skills because they're not having them. And I think the same concern applies here. We want to encourage them to be filling out the POLST forms. And at the same time, I'm starting to think, there may be something here to say palliative care teams should be filling out POLST forms. And if they're doing it, and when they fill them out, they should say, hey, somebody from the primary team, come on, join us. Mm-hmm. See how we talk through this. See how we introduce the POLST. Because there's a tremendous amount, like we were just talking about, of like poor quality conversations that lead up to completion of POLST, or no conversation where they just hand them the POLST and say, I'll come back and sign this tomorrow.
That's right. I think that would be really ideal if we can have these conversations together with primary teams in order to demonstrate how we're doing it and teach them and empower them to do more of it. I also think that for our teams in the Palliative Care Quality Network, as we've looked at this data and then moved forward from it into a multi-site quality improvement project, we've been really realizing that you can't just say, go hospital medicine, go primary teams, let's do more of these POLST forms. They're going to need to have some support to understand how to have these conversations. And it is helpful to have some quality control and really examine how they're having the conversations in order to tailor the ongoing education. Because it can be an intimidating form, and you're completely right. You can get a different outcome depending on how that conversation occurs.
That's really interesting. So tell us what else you think is really key to take away from your study?
Yeah, absolutely. And I think just taking that data about POLST forms a little further, we did look at patients in whom they had expressed a preference to limit life-sustaining interventions. So they had expressed a preference to be either DNR, DNI, or partial code, and who survived a hospital discharge and were followed by the palliative care team until the end of the hospitalization. And there still, advanced directives were completed for just 4.3% of patients, and POLST forms for 29% of patients. And then we looked at just the...
That is actually really interesting that the advanced directives are still incredibly low, but people are seeing utility of POLST over the advanced directive.
That's right. Yeah, definitely.
So POLST is superseding the advanced directive in some ways?
Or these teams are finding them more useful or easier to complete.
Yeah, maybe because they don't need a notary.
Yeah.
And it's a binding order as opposed to a general set of directives.
I think for all of those reasons. Yep. And then even amongst patients who are discharged to an extended care facility. So this is a SNF, for instance, or a long-term acute care facility, where POLST forms are actually legally required in many states, including California. A POLST form was...
Not legally required. Nobody can force somebody to sign a POLST form, right?
Or maybe it's a requirement of the skilled nursing facility to offer
bring it up and offer it.
Thank you for clarifying that. But still, POLST forms were completed for just 31% of those patients who had a preference to limit their life-sustaining treatments.
So individuals who were, let's say, DNR, of those individuals, only a third had a POLST form going to a skilled nursing facility.
Yeah. And so those patients are going to show up at the skilled nursing facility, and they're going to be provided a POLST as part of their admission process. And it's just a question of whether the conversation is going to happen really well in that setting, or whether it would have been better for it to occur in the hospital after the conversation occurred, during which it was recognized that they wanted to limit their life-sustaining treatments.
This is really interesting stuff. So here's another question. What if some of our listeners out there are really jazzed about this idea of the Palliative Care Quality Network and want to join? Is that a possibility?
Absolutely. So, yeah, we are a growing network, and we onboard teams every week. I think we're now up to about 88 teams in our network, and our geographic area is spreading. We also are working really closely with our other sister registries in the field, namely QDACT and CAPSI, sorry for the alphabet soup. But all of us are working together to try to get more specialty palliative care teams on board collecting data through a quality improvement registry so that we can analyze with greater and greater power. What are we doing? How is our practice varying? And what can we learn from each other to improve?
It's terrific.
And do you have any practical suggestions for teams wanting to improve, let's say, their POLST completions or advanced directive completions?
Yeah, that's a great question. I think some of the pearls that we've gained from our quality improvement project so far is that it's really helpful to have your data very visibly apparent. So to track your data and to look at it and to stay on top of it. And it's quite motivating actually to look at how your data compares to other similar teams. It's also really helpful to have a champion for a quality improvement project who really owns the project, keeps beating the drum and keeping it at the top of people's awareness. And then trying to change the system to make it a little easier to do the right thing more often. So whether that's making sure that there's POLST forms in the palliative care, a rounding room, or on all of the floors, making it easy and consistent for POLST forms to be scanned into the medical record and posted in a place where people can find them. Imagine that. Coming up with processes to make sure that when POLST forms are completed, they're actually sent with patients and patients get the education about how to use them, and family members get the education about how to use them into direct future care. So I think making the system smarter and more consistent to make it easier to do the right thing.
What's next as far as research for you?
Yeah, that's a great question. I think in the Palliative Care Quality Network, we really are interested in doing a deeper dive into our high-performing teams, the teams that do this and other care practices very consistently and well, and try to really do more direct observation and qualitative research to try to understand what is leading them to perform well and what could we learn from that could be disseminated to other teams in the network and beyond. I think also we recognize that the data collected here and reported here is necessarily very concise because we had to keep this data set to our 23 core items that are feasible for frontline clinicians to collect in the course of their usual care. But I think there's a lot more to be understood about exactly what was occurring during these consultations. How much of the time were we exploring values, hopes, fears, wishes, preferred place of death, et cetera. There's so much more to these advanced care planning conversations that we weren't able to capture in this concise data set.
It's really interesting. This is that question that Diane Meyer often asks about what's in the palliative care syringe. And this is an early glimpse because, as you say, a lot of people participating, but you can only ask so much. These are clinicians. This isn't a research study. These aren't research assistants. These are people on the front lines doing the work who fill out these forms. So you can only get so much. So you've got you can see the color of what's in the syringe, but you can't really do much more than that.
That's
so this
right.
sort of in-person look would be really interesting to find out more. And in addition to looking at the high-performing teams, it might be interesting to look at the low-performing teams as well to see what's happening there as a contrast. We look forward to more.
Thank you so much for the opportunity.
So thanks for joining us. Maybe we
see you
can
guys.
end with a little bit more of Landslide.
Thank you.
I took my love and I took it down. I climbed a mountain and I turned around. And I saw my reflection in the snow-covered hills till the landslide brought it down. Oh, mirror in the sky, what is love? Can the child within my heart rise above? Can I sail through the changing ocean tides? Can I handle the seasons of my life without you? Well, I've been afraid of changing 'cause I've built my life around you. But time makes you bolder, even children get older, and I'm getting older too.
took my love
And I took it down.